psychiatrist and founder of HealMed Solutions. I really want to give shout out to other presenters before me and panel discussions today, especially Tharapa. You guys are doing what sort of I am trying to do. So I'm so blown away with everyone today. Without further ado, I would like to introduce you all to HealMed, where me as a psychiatrist, I'm trying to tackle this challenge of mental health care accessibility to patients and help our providers to do that. We have filed patent for this and PCT along with it. So let's start with the problem, why we need to do something in this field. Essentially, mental health, as we all know, is really, it's the next pandemic that we all are seeing. This is a snapshot of America, where 96% counties have zero psychiatrists, unmet need, and 60% have zero psychiatrists as we speak. And to add insult to this injury, 60% of us are due to retire pretty soon. And someone mentioned earlier in the day that there is a mass exodus of physicians and clinicians, and there is no way humanly we can match that or bridge that gap, right? So that's one scenario where we have severe shortage of provider, and on the other side, mental health is on the rise. It's on exponential rise. It used to be 1 in 5 people suffering from some sort of mental health illness, and recent COVID, we know 60 to 80% people are reporting some sort of issues. So we all can very well see within our families, within our friend circles, we are suffering. We all are suffering essentially. Mental health spending fortunately has gone up, but we still have at least 300% backlog to tackle the problem. And what all this means is, and why I'm saying all these numbers, essentially, people are not getting care in timely manner. They're waiting 2 to 3 months to get an appointment. And if you are suicidal today or suffering seriously, you cannot wait 2 to 3 months. So they end up going to emergency room. And as physicians, we all know how that fares for ER team and the patient. They get frustrated, they ask same questions by nursing staff, by ER physicians, then they get consulted by psychiatrists who may not be there. And then this all escalates the symptom, and it's not the right place to provide mental health care. There has been increase in 40% visits to emergency room for mental health issues, and it translates into 40 million people per year, and 18 million children also do not have access to mental health care in timely manner. And again, emergency room becomes a default place for them to go. This is not just a problem in the United States, it's a global crisis. In Japan, 80% increase in suicide. You talk about Canada, psychiatry is the only field where I can start practicing without going through their examination process. Hong Kong, 2 years of wait time. UK, you talk about it. India, we have only 3,800 psychiatrists for 1.3 billion population, and 1 student is committing suicide every hour. So we have 32 crore students at risk. You get it. It's a problem. It's a global problem. We all know it. But what can we do when, on the other hand, we are grappling with the shortage of providers, right? So I have a little video for you guys to see what we are doing.
Behavioral health accessibility is in crisis in America. Providers are overwhelmed. Wait times for patients are unacceptable. There must be a way to leverage technology to lessen these challenges. Founded by innovative psychiatrist Dr. Nidhi Goel, HealMed Solutions assists mental health professionals in preparing initial intake assessments in a professional, private manner. The process begins at either the physician's office, hospital, or outpatient clinic. HealMed provides a digital assistant to guide the patient through their pre-visit interview. This assessment can be accomplished by the patient from home or in the office.
Please share with me what has been troubling you lately.
I can't concentrate. I'm having a hard time sleeping. I'm feeling really anxious, and I'm beginning to get headaches.
Providers review the dashboard and supporting materials prior to seeing the patient. This cuts screening times down from an hour or more to just 5 to 10 minutes. The assessment captures a clear, complete, color-coded dashboard summary for mental health professionals. This digital assessment is backed up by a full transcript of the answers with video snippets for review, along with red flags where answers appear inconsistent or incomplete. Providers finalize their focused evaluation, perform and consolidate their mental status exam, and prepare their own treatment plan just as they normally would. The HealMed assessment generates the appropriate billing codes so that office staff can easily charge the right amounts through to insurance. HealMed reduces evaluation and care provision time by more than 50%, cutting patient wait times and getting them help faster. To see this solution in action and learn more, please set up a personal demo. We'd be happy to take you through the product. Thank you.
So essentially why we need, how it works, you essentially got that. So when a patient reaches out to get an appointment, after registration, HealMed generates a unique code for them, and patient can take the whole intake evaluation. When I see a patient, I spend 45 minutes to 1 hour to get that history, which is unlike other medical fields where 10, 12 minutes are enough. And then I spend another 30, 40 minutes to type up that history. So essentially for one history taking process, I'm spending an hour and 30 minutes, which I should be using to provide them therapy, to discuss with them their plan, to understand them, and provide clinical care, which I'm not doing, right? So once a patient registers, they can take the whole assessment. It's voice-based. Nobody needs to know how to read anything, how to type anything, how to write anything. And based on patient's answer, the whole system continues to move forward and do the whole history part from them. It's at their own pace, no judgment there. If their sexuality is discussed, their gender identity, or their drug use or alcohol use, patients feel safe while doing it. And in time, this is it to the provider, and again in a category based, so they can see whether this patient has unipolar depression or bipolar depression. We are not calling the diagnosis, we are CDSS, but they can quickly review the dashboard, and in the end, the whole report is generated as a PDF, which is then transmitted to their electronic medical record using those FHIR APIs and all those technology words that we use. So essentially, that our time is saved. A provider can see multiple intakes in that hour, so 4 or 5, they're very efficient. And with CMS changing their billing code from rather than E&M and time-based, now medical decision-making is the new way to go. So even if providers spending 10 minutes, but they have this whole history done for them, in their medical decision-making, they can bill for this visit. So this is the basic flow of HealMed solution. We are HIPAA compliant platform. We are SOC 2 compliance ready, and we also contacted FDA, and they said we do not require any approval because it is a clinical decision support system. We are not digital psychiatrists. We are digital assistant to our providers. What are the value propositions for providers, right? The efficiency is the key. Even if I want to see more patients, I can only see 12 or 13 max in my daytime because, again, the time-based necessity in mental health world. So it minimizes the medical errors. It's a standardized way of documenting everything. It minimizes scribe errors, reduces medical legal liability, and especially with Cures Act, where now patients can ask for their own medical records. Psychiatrists were very afraid because we document based on what we perceive the situation, but this is in their patient's own words. So this also complies with that. Higher patient satisfaction score again, because they don't have to go through same questionnaire asked by different people, a med student, a resident, a ER nurse, or physicians. And provider, we can use them on their, clinicians. We should use them at the highest level of licensure rather than typing up the notes and stuff, which we all suffer from. Why does it matter again? Current wait times is 2 to 3 months. In some facilities, it's up to 6 months. And ER is, again, not a good option for patients to go for their mental health need. It's an immediate initiation to the treatment journey for patients. And multiple patients can do it in the same time because it's a cloud-based platform. For providers, it boosts their earning where they were able to see lesser amount of patients because of time crunch. Now they can see much higher volume without getting burned out, without compromising in the quality of life. And since, as I mentioned, it's a billable service now, so it helps not just psychiatrists, our primary care physicians, our family practitioners. With remote patient monitoring being mainstream now, there are new codes for behavioral health integration and collaborative care monitoring, COC and BHI, where without face-to-face physician time, patients can be monitored at home using digital technology, and we build for those services. And it's also primary prevention, right? someone mentioned earlier about different levels of prevention. So it's a great win-win for everyone. Overall, for facilities and healthcare facilities, why they should adopt, again, increase in ROI, and how does any hospital say you need to wait for 2 months before we can provide you care, which is happening in the world of mental health. It's a system-driven assessment, billable, again, all the same things that I'm repeating myself. Where we just stand today, we have successfully closed 2 accounts. One is in South Dakota CMHC facility. When we went to them, there was CMHC with outpatient, but multiple feedback and opportunities opened up from that, including something called as a new program link, where anyone who's picked up for mental health issues or domestic violence or something, rather than taking them to correctional facility, are now brought into a system where they can be triaged and determine whether they need to go to emergency room or to correctional facility, right? So that judicial system where we can unclog or utilize that system more efficiently. Same in school, where a child acts out and 911 is called and a person is taken to emergency room, they wait there till 2 a.m. and then discharge at night. Same cycle again starts. So can we do assessment using an app and then make an informed decision whether this person needs care right now or something can be done in again, the triage part of it. And remote telepsychiatry, again, medical wards and consults, our primary care physicians are the first line of defense for mental health. 70% patients just go to them. We only see 30% maybe. And in their 15-minute time slot, if someone says I'm suicidal or I've not slept in 2 weeks or I wanted to buy a gun to shoot myself, they get stuck there, right? Like, are they not going to spend an hour with the person or call 911 for them to be taken to emergency room where patient says, I never said that, right? So how do we unclog all these problems where a person can be given HealMed app, they do their assessment, and now in their own words, a very important decision can be made where this person needs to be triaged at this time. As I said, the Southeastern has been a lifeline for us. Cornet Health is a telehealth company in New Jersey, and we are in a very advanced stage of piloting with Avera McKinnon. It's a very large regional system in Midwest. They were the pioneer in electronic ICU, which was recently sold to Goel Care, and we are also in discussion with them. There are a lot of processes, tips, and audits and whatnot. We are going through those, learning all the hoops. Why we are a bit different? There are a lot of mental health platforms that have come in, but most of them are service platforms, or they are self-assessment of mood or anxiety, right? And then the patients are now using them as a toy. Okay, this morning I was happy. What's my mood now? This afternoon I was crying. What is my mood now? But that data is not that useful, because in the end, again, who's analyzing it and who's utilizing it, and for what? If the provider is so limited, what do we do with that data? This is my team, my partner in crime, Mr. Rapalu. He's AI specialist and CTO, and very fortunate and amazing advisors. And I couldn't include everyone here. Dr. Kapaska, CEO, former CMO of Avera McKinnon System. Mr. Baer has been with the CEO of KCO, Unisys, Huawei, and Dr. Kane, again, he's the pioneer in digital psychiatry world. And they do amazing research in clinical and other field of psychiatry, but they were also saying that the puzzle piece, which is how do we take all this research into the mainstream for patients and providers to benefit from anything? And so we are that low-hanging fruit where we actually can improve the efficiency of our providers and help our patients or consumers to get their accessibility in a timely manner. We also have this last piece of video teleconferencing on our platform, again, end-to-end thing, where rather than going to 3-4 different platforms for providing care, patient takes assessment, provider sees the assessment on the dashboard, and they can connect through the same platform to even do a virtual visit if they so desire. My humble request to all of you, please, if you can spread our word to the people for either more pilots or connection. We are live, and it's just not intake. It's also when the person comes next time, the system starts from the follow-up. Since then, what has happened? I bootstrapped it. I left my job 2 years ago just to put my full-time in it, and I've put in a lot of my own money. We were able to get 150K as a convertible note. So, but we need more money. My engineers are working for free. It just had been a very, very kind and humbling journey for me. And in any manner, like I'm seeking support in any manner that you guys can give me. Thank you. So we are creating a real world solution for real-time healthcare delivery.
Thank you so much for your presentation. I want to give opportunity to Jan to ask first because he didn't have opportunity.
Yeah,
to talk
thank you so
before.
much. This is really great. I think you're tackling like a huge problem that needs to be solved. So like it's great to see like you building that innovative solution. I would love to hear more about your user testing journey and kind of what are some of the learnings that you made and how did you react to those learnings? Because in particular, like I have two questions. Like I've seen doctors not wanting to adopt more than one system, the EMR. So like, how did you get doctors that they also look at your dashboard and then maybe have another system they have to look at? So that's one question. And the other question is, what was your decision to go for voice, and why is that the interface? And what type of other like learnings that you made like by presenting that to patients?
All excellent questions. I will go backwards. I was working at a state hospital when I designed it or thought about it. So my first real world testing was on severely treatment resistant psychotic patients. And I learned so much from them, including we had an avatar and they were like, some said it's creepy, some said it's great, and then how we learned from them. So if a severely disorganized person could take that assessment, then in a more normal or high functioning patients can do it. So that's how, so a lot of reverse engineering happened in this product. They told me this is not working, or this question is not working. Have you suffered from sexual abuse? Is suffering a trigger word? So a lot of that real-time feedback that I got from my patients was helpful in designing it or not having certain feature, and then generalizing the whole platform where instead of using gender pronoun, because now we have 52 different ones, right? And how do we make it so generic that it's not just tackling with postpartum depression? It can be used in a geriatric male versus a child with ADHD or school bullying. So a lot of thought process went into what will work and what will not work. Why voice-based? Again, most of, at least our clients, because of if they are suffering from severe disorganization in the thought process, their brain processing time is much different from a, if I may use the word, the healthy brain. So here where they don't have to read anything, or if they just understand basic English, they can do it. And if even still they're not able to respond to it, our system very gently asks them to just answer in a binary form. So yes or no. And it's a unique challenge, right? It's not a simple chatbot. A yes can be answered in 10,000 different manners. A patient can say, of course, yada, yada, yada. Are you joking to me? Like, and how do we find that intent to move on to the next thing? So that was the real world issues. And I think you asked me, there's one more part of it.
On the other side, on the doctors, like, because they are the people who have to use it. So what are your insights there?
And you're absolutely right. Doctors is the biggest barrier. How, because everyone is doing fine what they're doing, right? How do you then navigate them to adopt something different? So that is where the other channels play a role. So the front desk staff, the care managers, the nurses, staff, and social workers. So when the history is done and transcribed, that dashboard, because the integration can happen to their existing medical record. So all that process is done by someone else rather than the physician. Front desk staff will register the patient. Assessment is done. They can either print it out and put it in the patient's chart for doctor to review, or doctor can, again, the favorite bar for HealMed Web API on their desktop or phone or wherever they are, they can review. And again, that reverse engineering, is the radio button better? Is the drop-down menu better for a physician? As a physician, what works for me? That death by 4,000 clicks. Went into designing it to make sure that we as a provider shouldn't suffer from another technology, if that makes sense.
Great, thank you.
Yes, I would like to ask a question from an investor point of view. So what are you asking for so in this round?
So I desperately need money to go forward. Like I said, everyone has been working on for free in this. We have already put $250,000 into it, but I need to enhance the product. We have spent $20,000 in this PCT patent application. I need money for sure, and support. I mean, if physicians can support product if there is a need and speak about to implement it in their wherever they're working, that's a huge help. We need $1 million at least for next 12 months run, for sales, for marketing. We have great institutes in discussion with us, but I don't have that bandwidth to expand. I've developed the whole business sitting in my bedroom in New York City with my twin daughters last 2 years. This is a different world. I need to hire people for sales. I have to spend $0 in marketing. So I need a lot of support in different manner, like I said.
Thank you very much. We are running about 22 minutes behind, so I'm not sure if Vince's question is pressing or if we want to move on.
Yeah, very pressing question. So you basically mentioned that we have a big problem of a backlog. Great. With your solution, what do you think we can reduce this backlog from 3 months to what?
3 months to, as far as I'm concerned, next day or 1 week, right? It's like that 10-way highway into that bottleneck into one dirt road. So if 10 patients can take it tomorrow and a middle person can review it and say, okay, this person needs to be seen tomorrow by a psychiatrist versus they can wait for 1 week or 2 months to be seen. So just how do we, is this a simple anxiety versus this is really severe case? And it's a very comprehensive assessment, which even in 1 hour, I can do a domestic violence, social media, gambling issues. Is it, like I said, ADHD, PTSD, trauma? One client said in their history of 20 years seeing a psychiatrist, it was the first time they were able to convey that they found their father dead in the hallway when they were 8-year-old. So that gave me goosebumps that we are losing that art of science of medical delivery. We are just becoming machines now, typing up our notes. Yes.
In the interest of time, I think we can take this offline, but I want to give you one feedback. Since you already have deployed in North Dakota, so we need those numbers. When you come to the next investor presentation, like the previous person asked you, you need a lot of money. That is very difficult way to invest. So I think we should take this offline, and I would love to guide you after this event. Thank you.
Thank you so much. I appreciate it.
Yeah, thank you, everyone.